Okay, so welcome to this next video in which we are discussing asthma and anti-asthmatic drugs. Okay, so we're currently discussing stage 4 treatment for asthma. Okay, and we've discussed that what differs with stage 4 compared to the previous stages is that suddenly we are now moving on to oral drugs, drugs that are not taken by inhalation but are taken by the oral route. Okay, and these are again routinely taken drugs as a preventative measure to try and stop you getting asthmatic attacks. Okay, so we've just discussed the xanthine drugs, theophylline and aminophylline, okay, which work by inhibiting the phosphodiesterase enzymes, specifically phosphodiesterase 4 enzymes, although they themselves are non-selective phosphodiesterase inhibitors in the bronchial smooth muscle cells. Okay, and this results in the basal amount of cyclic AMP that is being produced by adenylyl cyclase enzymes in the bronchial smooth muscle cells building up to a level that's great enough to activate protein kinase A enzymes, and therefore the protein kinase A enzymes are becoming activated, and the catalytic subunits of protein kinase A can then go on and phosphorylate myosin light chain kinase and prevent it from being activated by calcium chymodulin complexes, hence preventing histamine and cysteinyl leukotrienes from being able to cause contraction of the bronchial smooth muscle cell. Okay, right. So the next drugs that we're going to talk about, which are again counted as being in stage 4 treatment for asthma, okay, are the cysteinyl leukotriene receptor antagonists. Okay, so cysteinyl leukotriene receptor antagonists, and these are going to be antagonists for those cysteinyl leukotriene receptors on the surface of the bronchial smooth muscle cells. Okay, so remember, what drives an asthmatic attack? Okay, well, fundamentally it's the mast cells releasing histamine and cysteinyl leukotrienes, which then act on receptors on the bronchial smooth muscle cells. Histamine works on H1 receptors, and remember, the cysteinyl leukotrienes work on this cysteinyl leukotriene 1 receptor on the surface of the bronchial smooth muscle cells. Okay, and both these receptors then activate the GQ cascade and therefore cause calcium to be released from the ER. Okay, now cysteinyl leukotriene receptor antagonists are hugely beneficial at reducing the severity of asthmatic attacks. Okay, so they hugely reduce how much your airways constrict, basically, and the way in which they do this is by blocking these cysteinyl leukotriene receptor type 1s. Okay, so let's show this. So let me just draw a smooth muscle cell here, okay, a bronchial smooth muscle cell, and then we'll now have this representing our cysteinyl leukotriene receptor type 1, okay, and I'll colour this in green, and basically this is this GQ/11 coupled G protein coupled receptor, okay, that can cause calcium signals and therefore contraction of the bronchial smooth muscle cell. Okay, now leukotriene receptor antagonists then are going to be antagonists for this cysteinyl leukotriene type 1 receptor. Okay, so I'll draw the drug molecule here in red. Okay, and they are going to bind to the type 1 cysteinyl leukotriene receptor, and they're not going to activate it, so they're not going to allow it to then activate GQ/11 heterotrimeric G proteins, but they are going to block cysteinyl leukotrienes from being able to bind to this type 1 cysteinyl leukotriene receptor. Okay, so if I show this, now the cysteinyl leukotrienes are no longer capable of binding to that cysteinyl leukotriene type 1 receptor, okay, and therefore they are not capable of stimulating that receptor anymore. Okay, so effectively you make it so that the bronchial smooth muscle cells are no longer actually capable of listening to the cysteinyl leukotrienes. They no longer respond to the cysteinyl leukotrienes. Okay, right. So these drugs are given orally, okay, and they're given routinely. Okay, now what examples then are there of cysteinyl leukotriene receptor antagonists that are used to treat asthma? Well, both these drugs end with the suffix lukast. So you have zafirlukast, okay, so zafir and then the suffix lukast, And then the other example of a cysteine receptor antagonist that is of note is montelukast. Okay, so again it ends in this suffix lukast. Okay, and for that reason, the cysteine receptor antagonists are sometimes also called the lukast drugs, or just the lukasts. Okay, right. So they are given orally. They're generally very well tolerated, okay, so they generally don't have too severe side effects, not compared to the xanthine drugs anyway. And they do hugely reduce the severity of asthmatic attacks, okay, so they hugely reduce how much your airways will constrict if you do have a asthmatic attack. Okay, right, so that's now stage 4 treatment of asthma done. Now what we're going to go on to is the final stage for asthma treatment, which is stage 5. Okay, so this is given if even stage 4 does not work. And basically in stage 5, what we do is we give oral glucocorticoids. Okay, so remember the 5 glucocorticoids that we saw before, they were all for inhalation. Okay, they were all dry inhalers. Okay, so they weren't oral glucocorticoids. In stage 5, we give oral glucocorticoids. Okay, and the main example of an oral glucocorticoid is prednisone. Okay, which is a prodrug and has to be converted to the active drug in the body, which is prednisolone. Okay, right. Now, prednisone or prednisolone, which is the actual active drug, is going to prevent asthmatic attacks in a different way to the way that the inhaled glucocorticoids are going to prevent the asthmatic attacks. Remember, the inhaled glucocorticoids, they worked on the T helper 2 cells that were actually in the lamina propria, and that's all they could work on, okay, and they prevented them synthesizing interleukin 4, interleukin 5, and interleukin 13. Basically, oral glucocorticoids are far more powerful. Okay, when you take a glucocorticoid orally, obviously it's going to have a much more wide-ranging effect than when you take it by inhalation. Okay, and oral glucocorticoids basically produce full-on immunosuppression. Okay, they stop the immune response, specifically the adaptive immune response. Okay, right, so how do oral glucocorticoids stop the adaptive immune response? Well, basically they stop the activation of T cells, okay? And by stopping the activation of T cells, you then stop the activation of B cells. So you stop any new adaptive immune responses being initiated. Okay, well, how do they stop T cells being activated? Well, let me just draw a picture of a T cell here then. Okay, so this can represent my T cell here. So here is its nucleus. And basically, if you remember how you activate T cells, remember, get signal 1 for activation, which is given by their T cell receptor binding to an MHC class II molecule. Okay, and we're now talking about a CD4 positive T cell, since that's the type of T cell that is specifically important for us looking at asthma. Okay, remember, for a T cell to become active, its T cell receptor, which I'll have here in red, okay, needs to bind to an antigen fragment presented to it by MHC class II. Okay, it also needs its CD4 molecule here to bind to the MHC class II as well. So I'll just show the MHC class II on the antigen presenting cell here. Okay, so here's the antigen presenting cell's cell membrane. Right, so in purple here we have the antigen fragment. Okay, and then in green we have the MHC class II molecule here. Okay, and then the final thing to colour in then is just the CD4 molecule. Okay, so remember that gives signal 1 for T cell activation. Okay, you then need signal 2, which is given by CD28 on the surface of the CD4 positive T cell, binding to a B7 molecule on the surface of the antigen presenting cell. Okay, so we'll have B7 here in orange, and then we'll have CD28 here in turquoise. Okay, and when CD28 binds to its B7 ligand molecule, it will then deliver signal 2 to to the CD4 positive T cell here. Okay, and signal 1 and signal 2 together then cause what? Okay, remember, those then cause the CD4 positive T cell to make these two new molecules, interleukin 2 and the interleukin 2 receptor alpha component. Okay, and then the interleukin 2 receptor alpha component joins the interleukin 2 receptor beta and gamma component on the surface of the CD4 positive T cell to make this complete interleukin 2 receptor, which I'll colour in purple here, and then the interleukin 2 is then secreted from the cell and acts on the interleukin 2 receptor, which is now complete, and that delivers signal 3, which then causes the CD4 positive T cell to start proliferating. Okay, right. Basically, oral glucocorticoids go into the CD4 positive T cells, and again, through this mechanism that we've discussed, they bind to glucocorticoid receptors, okay, displacing the heat shock protein 90 from the glucocorticoid receptors, and then these glucocorticoid receptors with the glucocorticoid bound go into the nucleus, dimerize like so, and then act as a transcription regulator. They change gene expression. Okay, and in these CD4 positive T cells in lymph nodes all over the body, the glucocorticoid receptor dimer with the glucocorticoid molecules bound is going to prevent the synthesis of interleukin 2 and interleukin 2 receptor alpha, and without those two molecules being synthesized in response to signal 1 and signal 2, the T cell cannot activate. Okay, so you stop all new activation of CD4 positive T cells and also CD8 positive T cells, although we're not particularly interested in that here. And if you don't have the activation of T cells, we know that you're not going to get any more B cells being activated. Okay, so you block any further activation of the adaptive immune response by taking oral glucocorticoids. Now, why is that beneficial in asthma? Okay, you might say, but we've already had the adaptive immune response. That has happened. We've already got plasma cells which produce IgE molecules if we've got atopic asthma. We've already got loads of T helper 2 cells in our lamina propria, whether we've got atopic asthma or non-atopic asthma. Surely we're working too late here. Okay, but the reality is that those plasma cells producing the IgE molecules and those T helper 2 cells producing the interleukin 4, interleukin 5 and interleukin 13, they don't live forever. They are removed eventually. Okay, and they have to be replaced by fresh adaptive immune responses. Okay, and now you're not going to get any more fresh adaptive immune responses being initiated, so eventually you're going to stop this allergic adaptive immune response. It will take a while whilst you're waiting for the T helper 2 cells and the plasma cells that you've already got to be removed from the body. Okay, but once that's happened, then you're not going to get any more fresh adaptive immune responses being initiated, and therefore you should see remission from your asthmatic attacks. Okay, so that's the most extreme treatment that can be given for asthma, basically. Okay, and oral glucocorticoids, they are not nice drugs to have to take. Okay, they have horrendous side effects. They cause effectively Cushing syndrome. It's called iatrogenic Cushing syndrome because it's caused by taking a medication. Okay, so they are left to last, basically. They're incredibly powerful, incredibly effective, and if you have got asthma that is life-threatening, obviously you want to take them, but they are not nice drugs. Okay, right, so let's talk about potential future treatments of asthma that are not currently used, but may be used in the future. Okay, so the first future treatment that I'd like to mention is a drug called roflumilast. Okay, and roflumilast is going to work in a very similar way to the xanthine drugs, except that it is a selective inhibitor of phosphodiesterase 4. So this is exactly what I was telling you about when we were talking about the xanthine drugs. Okay, the xanthine drugs, theophylline and emprophylline, they inhibit all phosphodiesterase enzymes, all different families of phosphodiesterase enzymes, whereas roflumilast is a selective phosphodiesterase 4 inhibitor. Now we think that the phosphodiesterase enzyme that is actually in bronchial smooth muscle cells, which is the one that it is beneficial to inhibit in the treatment of asthma, is a phosphodiesterase 4 enzyme, and therefore it would be perfectly fine just to have a drug that inhibits phosphodiesterase 4 enzymes. That would be just as effective, hopefully, as the xanthine drugs. Okay, and that's what roflumilast is. So potentially roflumilast will replace the xanthine drugs in the future and will have fewer side effects, hopefully. Okay, another drug that I mentioned as we were going through, okay, was the drug Xoluton, okay, which is an inhibitor of the enzyme 5-lipoxygenase, okay, which we abbreviated down to 5-LOX. Okay, now remember 5-lipoxygenase converts arachidonic acid into 5-HPETE. I'll just try and find the picture in which I discussed this. Okay, I got it. There's that. Just bear with me a second. Right, here it is. Right, okay, so here's my picture of the production of the cysteine leukotrienes. Okay, so 5-lipoxygenase carries out this first conversion of arachidonic acid into 5-hydroperoxyeicosatetraenoic acid. Okay, and if you can't carry out that first conversion, you can't generate the later cysteine leukotrienes. So effectively, this stops mast cells producing cysteine leukotrienes. Okay, so that should have a similar effect to the cysteine leukotriene receptor antagonists, i.e. it should block the cysteine leukotriene-driven bronchoconstriction in an asthmatic attack. So again, it should hugely improve asthmatic attacks and make them less severe. Okay, so that might also be a future treatment for asthma. Okay, now what I want to talk about is some monoclonal antibody therapies that at present aren't really used, although they are incredibly effective. Okay, and the reason that they're not at present used is because of how expensive they are. Okay, so let me talk about these now. So the first monoclonal antibody I want to talk about is an anti-immunoglobulin E monoclonal antibody. Okay, so it's anti-IgE therapy, which is effective in relieving atopic asthma, i.e. it's effective in stopping you getting allergen-induced asthmatic attacks if you are suffering from atopic asthma. And the way that it works is by neutralizing the anti-allergen IgE molecules that you have. Okay, now this drug is called omalizumab. Okay, so I just want to discuss what monoclonal antibody therapies are broadly, okay, so that I can make sure that everyone understands what the concept of a monoclonal antibody is. Okay, so I want to discuss what the difference between a monoclonal antibody preparation is and a polyclonal antibody preparation is, okay, because people find these concepts confusing, and the reason is that people try and apply these words to individual antibody molecules, and the words are, then you can't apply them to individual antibody molecules. They apply to a preparation of antibody molecules, not to an individual antibody molecule. What I mean by that is that they apply to an entire mixture that contains loads of antibody molecules. So here, let's say this is a mixture that contains absolutely loads of antibody molecules, and you can describe this mixture of antibody molecules as either monoclonal or polyclonal. Okay, so let me explain what the difference is then. So basically, if this mixture here is a polyclonal antibody against some antigen, and let's produce an arbitrary antigen here. So let's say this is antigen A, okay? And let's say all of the antibody molecules in this mixture are against antigen A, okay? The mixture is a polyclonal mixture of antibodies if the antibody molecules are not identical, okay? i.e., if they bind to different epitopes of antigen A, i.e. their variable regions are going to be different. So if I just highlight up the variable regions of these antibody molecules, if this is a polyclonal preparation. It will contain antibody molecules that have different variable regions and therefore which bind to different epitopes of antigen A. Okay, that's what is meant by polyclonal. So all the antibody molecules are against protein A, but they do not have identical variable regions and they do not bind to the same epitope of protein A. Okay? In contrast, a monoclonal antibody preparation is one in which all of the antibody molecules in the mixture are identical. Okay, they all have the identical variable region here, and they therefore all bind to the identical epitope of protein A. So they all bind to the same epitope of protein A. Okay, so monoclonal antibody preparations are far harder to come by than polyclonal antibody preparations, because the way we used to produce antibody preparations like this is we'd go to some poor animal, we'd inject it with protein A, usually a mouse, okay, and we'd wait for that animal to induce adaptive immune response and produce us loads of antibody molecules against protein A. Now, of course, those would be polyclonal preparations of antibodies against protein A, okay, because you'd have loads of different antibody molecules which would all bind to different epitopes of protein A being produced as part of the mouse's adaptive immune response. Okay, monoclonal antibodies have to be produced by artificial procedures. Basically what you do is you take one specific B cell from a mouse maybe, okay, which produces one specific type of antibody against an epitope of protein A, and then you culture that to simplify things down a lot, and then you can produce loads of that exact same antibody basically. Okay, right, so that's what is meant by monoclonal antibody preparations. Okay, so monoclonal antibodies are taking over in pharmacology, okay, because you can engineer antibodies to bind to whichever epitope of a protein you want, basically. Okay, so you can get incredibly selective molecules, basically, that target specific proteins, and that's something that's really, really helpful in pharmacology. Okay, so omalizumab, and you can tell when a drug is a monoclonal antibody because it ends in mab, okay, monoclonal AB for antibody. Okay, right, so omalizumab is a monoclonal antibody preparation consisting of loads of antibody molecules that all bind to a certain epitope of what protein? Well, the protein is an IgE antibody. Okay, so let me show this. So if I draw out the antibody molecule again, let's say this is now an IgE antibody molecule. Remember what that meant, okay? That meant that this this constant region here was a certain type. It was the Fc epsilon type, okay? So all IgE molecules have the same constant region, and it's this specific Fc epsilon type, so I might just put that in here. So this is an Fc epsilon type, a fragment crystallizable epsilon for E. Okay, and basically omalizumab is a preparation of antibodies where the variable regions here are targeted against some epitope of this Fc epsilon portion of IgE molecules. Okay, and when you give this to a person, this will neutralize IgE molecules against the allergen that have been produced against the allergen. Obviously, this is only useful in atopic asthma, where you have produced IgE molecules against your allergen. In non-atopic asthma, you haven't, so it would obviously be useless there. Okay, and it can stop the IgE molecules from mounting on the surface of mast cells, okay, and therefore can stop you actually getting asthmatic attacks in response to the allergen, because now you don't have the IgE mounted on mast cells, and therefore the mast cells are not going to respond to the allergen anymore. Okay, so that's omalizumab, and it does work. It's incredibly effective, okay, at stopping allergic asthmatic attacks. The problem is it's incredibly expensive, okay, so it's not currently used. Right, finally what I want to talk about is anti-interleukin 5 antibodies. Okay, so these are monoclonal antibody preparations where the antibody molecules, the monoclonal antibody molecules, their variable region binds to some epitope of interleukin 5. Now, there are two different anti-interleukin-5 monoclonal antibody preparations, and in these two different preparations, the antibody molecules will have variable regions which bind to different epitopes of interleukin-5. Okay, so let's just have interleukin-5 here. Okay, so these two examples that I have of anti-interleukin-5 monoclonal antibodies are mepolizumab. Okay, so mepo and then lizumab. Okay, and the other example is a drug called reslizumab. Okay, so mepolizumab and reslizumab. Okay, right. So, as I say, both of these are monoclonal preparations, so they contain loads of identical antibody molecules that bind to a certain epitope of interleukin-5, but the difference between the two preparations is that they'll bind to different epitopes of interleukin-5. Now, what they're going to do is neutralize interleukin-5. Now, why is that potentially beneficial in the treatment of asthma? Well, remember the central role of interleukin-5. The T helper 2 cells that come into the lamina propria, how do they cause the airway eosinophilia? One of the molecules that was really important there was interleukin-5. Interleukin-13 was important as well, so you won't completely abolish the airway eosinophilia. But remember, interleukin-5 was also important for then activating the eosinophils to release their horrible cytotoxic proteins, okay, and also transforming growth factor beta. So without interleukin-5, you're going to get less eosinophils coming into the lamina propria. You're going to be getting less horrible proteins being released by eosinophils and less transforming growth factor beta. So this should help to stop the airway hyperresponsiveness that is being maintained by this chronic inflammatory response, and hopefully once you've removed the eosinophils by stopping the interleukin-5, then the airway hopefully might be able to return at least somewhat back to normality. Okay, and therefore it should help to produce remission from asthma. Okay, right. So that now concludes our discussion of asthma and anti-asthmatic drugs. Well done for making it through all 14 of these videos.